welcome Dr. Claire Fuller, who I won't even attempt to read out the whole of her CV because it's vast. She's GP in Surrey, and she's the Chief Exec of the Surrey Heartlands Integrated Care System. But most significantly for our purposes today, she led a review a few months ago into the future of primary care. And we know that the vast majority of the contact that people have with the NHS happens outside hospitals. It happens in primary care. So the way in which primary care operates both now and in the future is really important to the people who use health and care services. So be very interested to hear what Claire's got to tell us about the future of primary care, and we will have an opportunity for questions and answers when Claire's spoken to. So be thinking about your questions. Claire, over to you.
Thanks very much, Helen. So hello, everybody. Lovely to see so many faces. So yeah, as Helen says, I'm Claire Fuller. I'm a GP and I'm the Chief Executive of Surrey Heartlands Integrated Care System. So I've reached the quite startling milestone that actually now I've been a GP longer than I haven't been a GP, which has caused more problems with my personal identity than I wish it had done, actually, which is quite interesting. And when I started as a GP, which clearly was a very, very long time ago, I became a GP because I wanted to look after people from cradle to grave, you know, throughout their lives within the context of where they lived and understanding what mattered to them, what was important to them. And when I started, we didn't have mobile phones, we didn't have computers, and actually you just did everything, and I lived on the patch. And it's not like that now. It's absolutely not like that now. And with great sadness, actually, you know, I still practice as a GP. And although I know many of the people I see, I will still in each surgery see people I've never met before and don't understand what is important in their lives. And even though you read the notes, it's not the same as building that long-term individual personalized relationship. So about a year ago, Amanda Pritchard asked me to look at primary care within systems. So what's working, why it's working, and how we could replicate it, with the aim of producing a report to go out to all of the ICSs to see how we could do things better. And I'm absolutely delighted to say that the national voices were fully embedded in the report, and actually the leadership from Sarah in particular during that was extraordinary, and Charlotte actually. So the leadership within multiple work streams was invaluable in terms of the insights. And we had Healthwatch involved, and we had many of you may know Fatima Khan Shah from West Yorkshire. She led the work stream we had on how better systems should work with local communities. When we kicked off the report, I met with each of the ICS, the Integrated Care System chief execs, and basically said to them, you know, what is going well in your system, what are you proud of, and what's not working, or what are the problems we need to fix. And the great bit was that actually everybody came back with great enthusiasm of things they were proud of. So there is a lot of fabulous work that is going on in primary care around the country. And what was also surprising was actually the agreement of the problems that we need to fix. And we really came back with the two problem statements of being, how do you improve access and how do you improve continuity? And very much view those as two sides of the same coin. And we'll all have been in that position where you want an appointment and you join the 8 a.m. scramble. You know, you get on the phone, you try and get through. If you do get through, you then get told call back at 2 o'clock, and you know you may or may not get an appointment. And we're all familiar with the anxiety, and you know, nobody phones to make an appointment because they're not worried about something. You know, and it's understanding how much each time one of those encounters increases individual stress and increases individual anxiety. So and that's not only for individuals, it's also for professionals. So as a professional, having someone coming in that you're trying to help that comes in really anxious and frustrated and angry because they've waited 3 weeks to see you, and means that you're starting the consultation in a non-productive way, which can actually lead to reduces our ability to do proper shared decision making, to properly design, to properly make sure we've got personalized care. And the other thing that happens because of the reduction in access is that people choose to give up the continuity, so give up somebody they know because they just want to be seen. And sometimes that's okay, and sometimes that isn't okay. So if it's my children who are in their early 20s, it really doesn't matter who they see. And actually they're of a generation where they don't care. So, if they've got a swollen knee, or they've got an injury, or they've got a weird rash, they just want to make sure it's not infectious, then actually it is less important. Although we know that if people build a relationship with health professionals, in terms of, if somebody tells you to stop smoking, rather than just random health professionals seeing you each time you see it, it will have more impact if it's the same person on repetitive occasions. So it is important. So the loss of continuity, because people are choosing to access care in a more transactional way, will pay a cost. And the people that are choosing to wait for the continuity are often some of our most vulnerable. So it'll be my mum and dad, won't it? So it'll be my mum's just fallen and broken her hip, and actually the thing that was worrying her, my dad's got Parkinson's and heart failure and diabetes. He's got, you name it, he's got all of them. But actually it's my mum that reminds him to take his pills, but it's then my dad that does stuff for my mum, and as a unit they function brilliantly. But the impact of my mum going into hospital unexpectedly has been quite catastrophic. And unless as professionals we understand the context of people's lives, we don't necessarily understand the importance of the shared decision making for people at their most vulnerable times. So my parents will always wait to see somebody that knows them, and actually the continuity of a record, although it's helpful, is not the same thing. So we need to get better about preserving continuity and also improving access. So in the report we talk about the formation of neighbourhood teams. Many of you will have heard of primary care networks, which cover a collection of GP practices that cover a population of 30 to 50,000 people. And sometimes primary care networks are brilliant, but often they're not. And when they are brilliant, they already work as neighbourhood teams. But when they don't work, actually, they are a series of contracts held between NHS England and individual practices, employing a couple of hours of a pharmacist over here and a couple of hours of a paramedic over here. And actually, they have very little impact on either how we deliver care or on outcomes for people. So we talk about making better use of these additional roles, which we have had significant funding to increase the number of people working in general practice and in primary care. But we need to make better use of them by working in teams. So we ask neighbourhood teams to do three things. The first one is improve integrated urgent care, so improve access. And that's about creating teams that deal with on-the-day demand by having a team led probably by a GP, but not necessarily by a GP, and collating all the demand that comes in and can be dealt with on the day, and making better use of community pharmacists, making better use of all of our other members of primary care, but also making better use of digital resources and dealing with things in a different way. The second thing we do is we ask people to look at how we look after our most complex patients. So identify who your most complex patients are, and then identify how you can wrap a team around them. But that team is not just made out of primary care, it's made out of community care, mental health services, from the voluntary sector, from secondary care, and actually create a team that works for individuals. So one of the areas of Surrey, we've looked at the moderate high users of healthcare and identified a population of 600 who are the 1% that use the most healthcare over the last year. And those 600 people have had 1,900 A&E attendances. They've had 450 outpatient appointments and 400 attendances. But on top of that, and just conscious of time, I normally would be slightly more pantomiming and get you to guess. So on top of that, this population, and all of you hold a number in your head about how many GP contacts you think this population have had. So these 600 people, on top of 1,900 A&E attendances, 450 outpatients and 400 admissions, have also had 54,000 GP contacts in a year. So that is why it is difficult to get access into GP surgeries, and that is why the workload is overwhelming and why people are leaving the profession. So we need a better way of looking after people that probably need team-based continuity to make sure that they can be seen quickly when they need to be, but also we can look after them in a more holistic way that works for them. And then the third lens that we ask people to look at through their neighbourhood teams is actually how we better improve health inequalities with communities. And this is building on the learning that we have from COVID about understanding how communities work and what is important to communities, rather than in the old days. In the old days, if I wanted if we were having a drive on blood pressure, we'd send a letter out, and if people didn't reply, we'd send another letter out, and we might do it 3 times, and then we go, well, they're a non-responder, that's marvellous. Now it means actually going and checking people's blood pressures outside the mosque, outside the schools, doing all of the rich learning we have in terms of how our communities work, but making sure both that our health professions have got time, but that also that we are making sure that our voluntary sector and our volunteers also have the time and our support, and that we are protecting people's time and working respectfully with people to improve health outcomes in a way that works. So my final and in the report we talk about the right environment to do that, which is about data and digital, so single patient record that should be accessible by people. So our customer facing it is terrible. So, to try and change an appointment, you could spend hours on the phone and still not manage it. And we don't make it easy for people to help us. We need to think better about our workforce and our leadership and create more flexible roles for people to be able to work as it and when it suits them. So understanding that, at times in life, you may only be able to do 2 hours on a Thursday, but actually that's okay. And we should facilitate roles that work for that, but allow people to build on as their lives change and they are able and want to do more work. And then we need to think about our estates. So at the moment, GP estates are in particular a terrible way. On a Friday morning when I work what's affectionately known as the cupboard, and it's called the cupboard. There's no examination couch. So if I need to examine someone's abdomen, I've got to wait for my colleague next door to finish, then say, oh, would you mind going with the patient I've got to go in and then come back out, which is just, it's not ideal, is it? Disabled access regularly being through the bins and upstairs consulting rooms with no disabled access. We need to think about estate differently. So it's not just NHS estate, it's not just one public estate, it's also about how we work, how we deal with commercial estate as well. So it is why are we not delivering healthcare to people in the high street, which then regenerates the high street, increases the footfall, but also it means that we've got really good transport links, and it works within the context of people's lives. And then the report was published in the summer. Couple of things have happened since then as we move into implementation so I've increasingly realized, I wrote a report, I was asked to write a report about primary care. I've actually written a report about how systems should organize themselves and how we should actually deliver our business in a way that works with populations in geographies. And thirdly, that this actually is a massive change problems in the way professionals work together and work with the public, and that as a change programme, we mustn't underestimate how hard that is going to be. So at the same time, we asked the King's Fund to do a global literature search looking at how change has been delivered in primary care, and the search showed that actually in England we have relied more heavily upon centralised financial incentives than anywhere else in the world, and there's little evidence it improves outcomes. We know it drives up activity, but not necessarily improving outcomes. And the places where they have done this successfully, what they've done is they've created teams with a clear remit and clear purpose, have given them data and have left them alone. So it's basically, it comes back down to give people data and work in a high trust environment rather than from a top-down way. So, Helen, I think that's for 15 minutes. Really happy to take questions on anything, as you know.